All right, we're about to break down the complete head-to-toe health assessment. My goal here is to make this stuff really stick, so you can walk into your exams feeling great and, more importantly, feel confident out there in your clinical practice. Let's dive in. So, right out of the gate, let's start with a really important question. See, there are 4 standard steps to a physical assessment, but there's one body system where if you get that order wrong, you could mess up your entire exam. You could actually create false findings and miss a super serious emergency. So stick with me because we're going to make sure that never happens to you. Here's our roadmap for today. We're going to start with the core 4, the basic rules. Then we'll journey from the head and chest down to that crucial abdominal exception we just talked about. From there, we'll get into blood flow, how to measure consciousness, and then we'll wrap it all up with a quick-fire review of the absolute must-knows. Okay, first up, the core 4. I want you to think of these as your fundamental toolkit. These are the 4 techniques you're going to use to assess pretty much every part of the body. Nailing this sequence is absolutely non-negotiable. And here they are. First, inspection. You look. Second, palpation. You touch. Third, percussion. You tap. And fourth, auscultation. You listen. Now, the golden rule here, the one thing you can't forget, is that inspection is always first. You have to use your eyes before you use your hands. So this sequence, IPPA, is your default mode, for almost everything anyway. So let's start our journey at the very top, the head, neck, and chest. This is where you find the body's control center, the brain, and its engine, the heart and lungs. The clues we find up here are absolutely critical. When we're checking the eyes, a normal finding is summed up by the acronym PERLA. Now, that stands for pupils equal, round, reactive to light, and accommodation. We're going to focus on that last A for a second, accommodation. So to test it, you'll have your patient look at something far away, and then suddenly focus on your finger right up close to their face. You're looking for 2 things to happen at once. Their pupils should constrict, and their eyes should converge or kind of cross just a little bit. Moving down to the neck. When you palpate lymph nodes, you're basically a detective looking for clues. Are we dealing with a simple infection or something way more serious? Infected nodes, they tend to be tender, they're kind of soft, and you can move them around under your fingers. But malignant nodes, totally different story. They're usually hard, non-tender, and feel like they're fixed in place, stuck to the tissue underneath. Big difference. All right, now let's put on our stethoscope and listen to the lungs. There are 3 main bad sounds you need to know. First, crackles. Think of the sound of Velcro being pulled apart. That popping sound means there's fluid in the little air sacs, which is a classic sign of heart failure. Then you have wheezes. That's that high-pitched musical whistle. It means the airways are narrowed like in an asthma attack. And finally, ronca. This is a low-pitched, snoring sound caused by mucus in the bigger airways. Sometimes, this one might actually clear up if the patient gives a good, strong cough. Okay, now for the heart. To remember where to listen, we use a really simple mnemonic, ape to man. It's just a silly way to remember the key spots, aortic, pulmonic, Erb's point, tricuspid, and mitral valve areas. Knowing these 5 landmarks is how you're going to accurately hear what the heart is doing. Okay, remember that question I asked you at the very beginning? Well, we're here. We've arrived at the big exception to the rule. This is the one body system where if you follow that standard IPPA sequence, you're making a huge mistake. And here's the change-up. For the abdomen, you must inspect first, and then auscultate second. You have to listen before you touch. Why? It's simple, really. If you start poking and tapping on the belly, you can stir up activity and create bowel sounds that weren't actually there to begin with. You'd be charting false information. So remember, for the abdomen, it's always look, then listen, then feel. This is why it's so important. Hearing no bowel sounds could mean a paralytic ileus, which is a true medical emergency where the bowel has basically shut down. And you can't just listen for a few seconds and make that call. The rule is you have to listen for 5 full minutes in a quadrant before you can legally and safely document that bowel sounds are truly absent. 5 minutes. Okay, moving down to the arms and legs, you're going to run into a lot of blood flow problems. Your job is to figure out what's going on. Is this an arterial problem, where blood isn't getting to the tissues? Or is it a venous problem, where blood is getting stuck and can't get back to the heart?
This chart makes it super clear. With arterial insufficiency, when blood can't get there, the limb is going to be pale and cool to the touch. It makes sense, right? No warm, oxygenated blood is arriving. You'll also feel a really weak pulse or maybe no pulse at all. Now, with venous insufficiency, the blood is just pooling. So the temperature feels normal and the pulse is fine, but you'll see this classic brown discoloration on the skin and a whole lot of swelling, or edema.
And now for our final system check, the neurological system. The big thing here is to get past subjective words like, the patient seems groggy. We need an objective tool to put a number on a patient's level of consciousness.
And that tool is the Glasgow Coma Scale, or GCS. A perfect score is a 15. That means your patient's eyes are open, they're talking to you normally, and they're following all your commands. That's our baseline for someone who is fully alert and oriented.
Now, this is the number you have to burn into your brain. A GCS score of 8 or less means a severe brain injury. It means the patient is in a coma. There's a famous saying in medicine, less than 8, intubate. That's because at this level, patients usually can't protect their own airway. It's that serious.
So how do we get to that number? It's just the sum of 3 different categories. First up is eye-opening, which is worth a max of 4 points. Second is their verbal response, worth up to 5 points. And third is their best motor response, which can get as high as 6 points. You just take their best score from each category, add them together, and that's your GCS. Okay, time to try it out. Let's say you have a patient who fell off a ladder. Their eyes only open when you apply a painful stimulus, like a pinch. Verbally, they're not making words, just mumbling some sounds. And for their motor response, when you apply that painful stimulus, they pull their arm away from you. So, looking at the chart, what's their GCS?
You got it. The answer is 8. Let's walk through it. Opening eyes to pain gets them 2 points. Mumbling incomprehensible sounds is another 2 points. And withdrawing from pain is 4 points. So you add it all up. 2 plus 2 plus 4 equals 8. And that score confirms this is a severe neurological impairment, putting them right on that critical threshold.
Wow, we have covered a ton of ground. So let's bring it all home and do a final, high-yield review. We're going to focus on the things that are most important for your exams, and of course, for keeping your patients safe. Here are the top takeaways. Number 1, always, always, always listen to the abdomen before you touch it. 2, a GCS score of 8 or less is a major neurological emergency. 3, a hard, fixed, painless lymph node is a huge red flag for malignancy. And 4, a pale, cool limb with no pulse is screaming arterial blockage. These are the life-or-death findings you absolutely cannot afford to miss.
You know, if you forget everything else from today, just remember this one thing. Your assessment starts with your eyes. Inspection is always first. The only time you break that rule is for the abdomen. That's when you look and then you listen.
And we'll end here. An assessment is all about collecting data, right? It's gathering clues, like a detective. But that's not where the job ends. The real question is, once you have all those clues, what are you going to do about it? What is your #1 priority action to keep that patient safe? Answering that question, that's the critical thinking that makes a truly great nurse.